This is a presentation about something that we currently receive huge feedback and a lot of interest and questions, both from surgeons and patients, which is what's called the Buttock Push-Up, which sounds a little bit dramatic, but in the end of the day, it is about so-called tissue-enforcing scaffolds, which is a big thing in plastic surgery generally, and in current aesthetic surgery, this is something that many of you will possibly have heard of as something that's called internal bra. What is an internal bra? An internal bra is sounds a bit boring, a polyhydroxybutyrate mesh, a synthetic scaffold, which consists of a material which is very, very, very compatible with soft tissue, with human soft tissue, a synthetic material. And what it does, if you place it in a certain layer, the body will degrade it and form a supportive tissue layer. Indications are in breast uplifts. Generally, I've really come to love to use them, especially if you have recurrent ptosis, people where you do an uplift with all your dedication and love, and the tissues just don't hold it, and you want to reinforce it. People with down-pointing nipples, like got candidates, or if they want to upgrade implants within reason. This is what it looks like in this famous internal bra. So when you do your breast uplift, after you've done your skin excision, you bring the implant between the implant in the gland. In the buttocks, the concept is and I think it might even be, for my liking, even more interesting for the buttocks, because you can, with a specific design of that mesh, which I'm showing you now, which we've been working on very intensely for a while now, I get the effect of a kind of suspended tights, that lift the buttock a bit up. So you've got like a circular enforcement, a medial enforcement, and an outwards enforcement, like a bit of a push-up effect. And in this sketch, you see what it then looks like in the human body. So if that implant deep inside the muscle and the mesh is wrapped around it, here a little animation of how that works. You see, for example, weight loss patient, muscle can't really hold the implant. You haven't got much capsule to lift the pocket up. I mean, you can, but the capsule tissue may not hold it that well. And then forming a mesh layer around it, that may really be a fantastic option to reinforce your soft tissue layer and strengthen the slightly intended muscles so they hold the implants better. So who's it for? Primarily in our practice currently, it is, I think, a very nice option for secondary cases. And secondary cases may have medical or aesthetic reasoning, is what we unfortunately sometimes see in buttock implants. I think it's mostly in massive weight loss patients, but some people, some are more prone to that than others. This is what we call an accordion phenomenon. That means that the muscle distends to a certain degree, that even if your buttock implant pocket is very deep, to a certain degree it can happen. Usually it's not dramatic, but this is the way that the muscle responds to the implants, and this is a great indication for using a supportive scaffold. And how careful. You can also use it for upsizing implants. Let me make clear, because some of our patients now seem to think we have kind of day of the open door to endlessly upsize buttock implants. No, you can't do that, but for a limited upsize, yeah, you can do that. And if you have something that's called secondary soft tissue atrophy. In primary cases, I'm considering for patients with extreme weight loss who have not so good soft tissue covered, or so-called low-centered buttocks. I explained to you now what that is. Now here is probably, let's say, what in buttock surgery we'll call a home run, a fantastic precondition, a great case where a patient with a relatively short pelvis and a short muscle, and here with even an implant that is not so terribly big, you get an extremely cracking result. But the result is always the implant plus the body of the patient. It's not only the implant, so that really worked out very well. And now this is an example for a low center low center gravity buttock. Please, I'm always making clear this is not my patient. It's just that I find this person, I don't even know who it is, very fascinating, because it's a photo that many patients show me, and some say I love it and some say I hate it, because you see the pelvis actually is here a bit longer and the buttock sits a bit lower. So this is an anatomy related thing, and this is something where with, for example, a scaffold, you can to a limited degree work to change the anatomical conditions of the patient. In a rough summary, what speaks in favor, what speaks against scaffold use, it's a favor definitely. It's a very, very robust option to strengthen soft tissue and stressed muscle tissue. It's a biodegradable material. It's a great thing. Con, I'm afraid, is going to be the costs. You need a lot more material in the breasts, so I think it's a very cost-effective thing. It's technically a bit demanding to place it, but once you are comfortable with this, you probably love it. We haven't so far had the experience that it has a high seroma rate. That's probably the first concern that most surgeons will have. We'll have to see that over the years, but so far it hasn't given us any more problems, but we're always a bit more cautious in aftercare about this with patients. And I'm running through a few case examples here. There's a purely aesthetic reaugmentation, a really cool patient that came, had I think 300 cc implants before, and then said, even directly after the first surgery, afterwards I want bigger implants. And with bigger implants you always have to be careful, because you don't want to stress the soft tissues. And this is, I think, a great example. You upsize it from 300 to 410 biconvex, and biconvex are a little stressful for tissues, but together with a supporting scaffold, a fantastic thing. Again, here I want more upper pull fullness, and there you can, to a certain degree, both strengthen soft tissues as well as a little bit tweak the anatomical limitations that we have with each case. This is I think very, very interesting case, because here we had a typical what we call accordion phenomenon. There's tension on the muscles. Here I think we're pretty sure why, because the patient developed a seroma. There's always a risk if you're physically a bit too active in the immediate period, and the fluid distends a bit the muscle, and it doesn't hold the implant that well. You see the super swollen look directly afterwards, and the muscle giving in. But that's a brilliant indication for using scaffolds, because you just then secondarily have to put that scaffold or that push-up and lay around the implants, and you can reconstitute the original strength of the muscle tissue surrounding the implants. So for these cases, I think it's really, really a nice solution, because without enforcement, that can sometimes be a little bit frustrating. So in conclusion, I think it's a great option for secondary buttock implant surgery. Word of caution, upsizing possible, but no, not without limits. You can create some nice, more upper pull fullness. Always hold your horses with too much volume increase, and that's a really strong option, if you have this before mentioned accordion phenomenon, weight loss patients who don't really cope so well with the implant. You can strengthen your recipient side. I think for primary buttock implant surgery, to my humble opinion, I don't think it's really necessary. They usually work very well without these things, and I think just probably the costs of this will hinder this a little bit to become an everyday bread and butter option for primary buttock implant surgery. It's like a primary breast augmentation. I don't really think that there is any indication to use scaffolds apart from complicated cases. It comes with a bit of a technical challenge, but again, it's like all these things. Once you've done it a few times, you feel very comfortable with this. I think it's a bit of challenge. There's a bit of a challenge in patient aftercare, because patients with a secondary procedure tend not to have any pain, and then they might move around a little bit too much, and I'm always concerned that this might cause more seroma, although luckily so far it's not happened. So this is a part of our program for our Life Surgery Congress in June. So this will be something that I'll be showing live. We don't do pre-recorded surgery, so guys are coming here and we are doing all that live. I hope with a lot of presential contributions here, and but we do it hybrid anyway, so just in case. But I hope to show you this on this occasion, and again, you know, we're open minds for a very, very interesting surgical option, and this is what surgery in the end of the day is about. Stay curious, move forward, find new and better solutions, and I think that's a fantastic example.